Dr. Sanjeev Gulati really does not need much introduction in this group. He very efficiently strides over the worlds of pediatric nephrology as well as adult nephrology, and there is really no better person to take on this topic. How is pediatrics a different ballgame when we come to organ transplantation and more specifically kidney transplantation? Dr. Sanjeev.
Thank you, chairpersons, and good morning, everyone. At the onset, I'd like to congratulate Raji for getting this pediatric transplant symposium on board. I think, as he rightly said, this is the first time we have been able to do that, and it's a small beginning, but I'm sure we will make it ensure that it's a regular feature. So the topic that has been assigned to me is kidney transplantation. Is it a different ballgame? And over the next few minutes, I'll present you data to show how it really is. But first and foremost, just to quote Nelson Mandela, that there can be no keener revelation of the society's soul than the way in which it treats its children, because children's health is truly the nation's wealth. And that is the reason that children should be prioritized as far as kidney transplantation is concerned. However, there are numerous challenges which make these children unique and different from adults. First and foremost is the social challenge itself, where there is a mind block in the parents, the pediatricians, and the child is, unfortunately not the decision maker in the entire scenario. There are economic issues. Barring few exceptions, there is no state funding. There is no employer funding. And these children, more often than not, are not insured. There are immunological issues like higher risk of rejection. There are surgical issues like abnormal tract and size. Dr. Guleria is coming in. I'm sure he'll take it in greater detail. There are medical issues like vaccination, immunosuppression, infections, growth, and recurrence, which are very unique to children. Then, not to forget the psychological issues. These children are more concerned with their cosmetic issues, and compliance often takes a backseat. So, as far as renal transplantation is concerned, I think there's very little doubt it's the gold standard for renal replacement therapy, because this is the only treatment which will cure uremia, give best quality of life and survival, high rates of complete rehabilitation and schooling, cost effective in the long run, and mind you, it has got superior patient survival and comparable graft survival to adults. And this is one thing we need to emphasize to the families, because what I find quite a dichotomy. In the same family, a 60-year-old would very readily get a kidney from the family, whereas if the patient happens to be a child, the parents are in doubt. Now, looking at the immune responsiveness of children versus adults, now young children actually may represent an immunological defined subgroup distinct from adults and perhaps at a higher risk for renal allograft rejection. In fact, children under 5 years have increased numbers of CD2, CD3, CD4 lymphocytes when compared with older children. Young children also have higher than expected functional indices of cellular immune function. And children and young adults produce lymphocytotoxic antibodies in response to blood transfusions more frequently than adults. So you are dealing with a much more immunologically active patient. And these are some of the studies. The average change in the GMP for CD4 T cells was significantly greater in children, both at D10 and D28. Again, when these were the T cell responses to LAIV were more vigorous in children or adolescents as compared to adults. Again, highlighting that this is a subgroup which is much more immunologically active when you look at the overall children versus adults. Surgical. So children present a lot of surgical challenges. Abnormal urinary tract is one of them. A lot of them, as you know, Kakut is the commonest cause of chronic kidney disease in children. This is a 9-year-old boy who had an anorectal malformation, an ileocystoplasty, recurrent UTIs. He had to undergo a mitrafanoff, he had bilateral ureteric implantation, and not surprisingly ended up in chronic kidney disease. Came to us in 2012, he was from Nagaland, a very committed family. So you can see, despite all these, morbidities, they decided to go ahead with kidney transplantation. Serum creatinine on follow-up was 8, no UTI. So what tells us this patient tells us is that a detailed urological evaluation for transplant intervention should be done, which include medications, Botox injection, intermittent catheterization, sometimes a bladder augmentation, or at times even a supravesical diversion like a metrafenov, as in this index case. And therefore, a pediatric urologist has to be a part and parcel of your surgical evaluation. The recipient size is often a challenge. And world over, when the transplant program started, for many, many years, we never used to accept more than 10 children under 10 kgs for a kidney transplant. There's a 4-year-old boy who had weighed 10 kg, more looking like a 2-year-old child. He came to us with chronic kidney disease, chronic interstitial nephritis. The father brought him all the way from Southeast Asia, Cambodia. I still remember he had wrapped him in a bag when he couldn't even walk. So we stabilized him on an automated peritoneal dialysis. On 15th of March 2013, we finally went ahead with the kidney transplant after he was optimally stabilized, vaccinated. This basiliximab induction was given, TAC, MMF, prednisone, and 5 years follow-up. Serum creatinine was 0.4. He was attending school. This was one of the lowest birth weight children that was transplanted in the country. Now, this is another girl who was a 14-year-old when she came to us, had end-stage kidney disease secondary to reflux nephropathy. And when we counseled the family regarding kidney transplant, they were quite undecided. They had seen actually 3 leading nephrologists, and all of them uniformly, besides their treating pediatrician, had told them not to go ahead with kidney transplant. So I was an HCPGI Lucknow, and anyway, I told the family, at least, you start this girl on dialysis. To add to our problems, she had developed pyrexia of unknown origin, which turned out to be tuberculosis, and was started on ATT. But this girl was not doing very well on dialysis. So the 2 major issues that we faced were, one, the social concerns, that the mother was ready to donate, but they weren't sure what this girl is going to do later on in life. And finances were another issue. So we tried to negotiate both of them. As far as she underwent, finally, we involved the school in the fundraising program, and in no time, we could get through crowdfunding the entire amount. Then came the social issues, and we, counseled the family that transplants, by and large, the outcome has improved. So mother finally went ahead and donated a kidney. So she was, I remember, in class 8. Subsequent academic career had been exceedingly brilliant. I would say among the top 5%, if you see. So she did a bachelor's of engineering, a master's from the prestigious Indian Institutes of Technology, and now is a faculty of Indian Institute of Technology. Got married. Ultimately, yes, no doubt, after good, as you can see, 18 years, had chronic graft dysfunction, came back to us for a second transplant, but by this time she had got married, and the husband, without even an inch of doubt, came forward, donated a kidney, and she is currently 10 months post-transplant, having a normal kidney function and teaching at this prestigious institution. So, we never know what life has in store for us, but this was the outcome. And the biggest roadblock was not the family. It was the pediatrician and some of the adult nephrologists. Unfortunately, there are none in the audience. Now, one of the other challenges that we face is a medical challenge. So we have to optimize these children in the pre-transplant period. We have to make sure that they are vaccinated, something which is very unique to children. Again, once these children are transplanted, they get an adult kidney. Pre-transplant fluids and electrolytes are an issue. You have to rigorously hydrate them. Graft function, we need to keep in mind, needs to function for a much longer time. Immunosuppression, ideally should be non-nephrotoxic. They have a much bigger life ahead, so you have to look at the risk of malignancy, facilitate growth, and at the same time it's affordable. So all these are big challenges which are pretty unique to the pediatric community, more so because they have no funding source, at least in India. Share with you another case, a 12-year-old boy. He came from Tajikistan, and this child was labeled to have severe heart failure, diffuse cardiomyopathy. And so much so that he was bedridden. He couldn't even walk 2 steps. He had been to a few hospitals, uniformly advised to not to pursue transplantation. When we evaluated him, he had a severe pulmonary artery hypertension, ejection fraction of only 10%. And to my mind, this appeared more of under dialysis. Fortunately, we had a very good pediatric cardiologist at hand, and who gave us a lot of confidence. So we put this child on daily dialysis, and as you can see, the ejection fraction actually improved 25%. So this boy, who had been rejected by at least 3 programs by the anesthetist, ultimately went ahead with the kidney transplant in 2013. Post-op course has been uneventful. 10 years post-transplant, a social visit, serum creatinine of 0.6. And from a boy who could not walk 2 steps, he is now in the school boxing team. Now, opportunistic infections are another issue. They are a permanent risk in patients receiving immunosuppressive therapy and may impact allograft survival. And children more often are a D plus R minus, which means that they are CMV naive. So they are at a much higher risk of developing CMV infections. BK virus infections are again another issue. EBV infections, PTLD, fungal infections, and therefore the need for optimization of immunosuppression and continuous surveillance, not to forget the pre-transplant immunizations. There's another child who got chronic kidney disease at 2.5 years of age, was on regular follow-up, and by the time he reached 4 years, since the family had been on regular follow-up, they were very committed, and we had no issues getting him through a preemptive transplant at 4 years of age. This is just early pre-transplant period. But for the 5th day post-op, he developed a post-transplant varicella and a lower respiratory tract infection. As you can know, in an immunosuppressed patient, it can be horrendous. We were lucky, we treated him and he recovered. And today he is 18 years post-transplant. As you can see, this is through the journey. And he is now studying his first year NG. He's completed his school. So he got a kidney transplant prior to starting schooling, and now he is in college, a budding engineer. This is another patient I would like to share with you, a very committed family again. A first transplant which he received, I think, at 4 years of age, had renal vein thrombosis, graft failure. Family again was very committed. We put him on automated peritoneal dialysis, stabilized him over the next 2 years, went ahead with the second transplant, and thereafter has been on cyclosporin, MMF prednisone, which we used at that time. Post-transplants, 1.2, creatinine 1.3. At 8 years post-transplant, he came to me with a serum creatinine of 1.5, which had bumped up. So we quickly did a graft biopsy, which showed interstitial infiltration. There was no tubulitis, so the suspicion homed on to a BK virus. We did a BK virus PCR, and indeed he had BK virus nephropathy. So we put him, we stopped MMF, we put him on leflunomide. His PCR count improved to 0. Had another brush in the COVID pandemic, was readmitted with us in the hospital, and as you can see, he is about 18 years post-transplant, serum creatinine of 1.6, and he's got married subsequently, he's got a baby. He's not only that, he's handling the family business and also taking care of his elderly parents. CMV infection, as I told you earlier, is another bugbear because, most often these patients are CMV naive. They get a kidney from from adults who are generally D+. This is a patient which we transplanted in March 2009, was in a steroid-free protocol, so he received aggressive induction. Thereafter was on TAC and MMF. He developed graft dysfunction, CMV disease, treated him with Valgan cyclovir, switched him to TAC and EZA, developed a chronic antibody-mediated rejection, but yes, he survived. 9 years post-transplant, serum creatinine of 1.9. Now, these are certain unique infections to tropical countries like India. This was a patient who came to us for a follow-up visit, but unfortunately, he landed in Delhi in the midst of a dengue epidemic and caught dengue. He developed graft dysfunction, he developed proteinuria. When we biopsied him, he had mesangial capillary glomerulonephritis. So we put him on a combination of losartan and ramipril, reduced the proteinuria. Post-transplant lymphoproliferative disease is perhaps the commonest malignancy after pediatric transplants. 2 to 4% of these patients get it at a median of about 14.9 months. Again, this is something which we don't see in adults that commonly. Highest risk group comprises the EBV naive patients, just like the CMV. These children are more often than not EBV naive and transplanted with EBV positive donors. And treatment is aggressive reduction of immunosuppression, risk of acute rejection of the graft and development of DSA, which can lead to graft failure. In the NAPATIX database, they had the largest series of 92 PTLD patients, which had a 70% graft survival at 5 years versus 78% without PTLD with a hazard ratio of 1.59. So the treatment is aggressive immunosuppressive reduction. Non-compliance is another issue, which is perhaps far higher in children and adolescents. Not surprisingly, it leads to acute rejection and graft loss, and compliance can be improved by avoiding cosmetic side effects. Fortunately, now we have switched to tacrolimus. There are less cosmetic issues. We also need to keep in mind reducing the pill burden, at the same time reducing the cost, which is a major issue in countries like India. Patient education, parental supervision is another way to talk about it. And again, partnering with the industry, I have a paper on one of the patient support programs which has significantly improved compliance, which I'll be presenting later during the day. So this is one such child, which we transplanted in 1993. CKD had chronic interstitial nephritis, was in CSA, cyclosporin, prednisone, was coasting along very well until 2007, had a fight at home, stopped immunosuppression, and the consequences, it didn't come for follow-up. By the time he came to us, it was too late. We biopsied him, he had chronic rejection, we put him on hemodialysis, got in a second transplant, but this is a reality, Subsequently, he was one of the unlucky guys. 2020, he had a severe bout of COVID and we lost him. This was in the height of the pandemic. There was no beds available in Delhi. I still remember we were trying to manage him at home through telemedicine, but he was one of the few that we lost. Again, preemptive transplantation, I think, without doubt, should be the goal for children because it saves money and improves the quality. So these are children that we have transplanted, and we have published this in Indian Pediatrics. We have among the largest series of preemptive transplantation. Donor-recipient size mismatch is something that we need to keep in mind. Again, unique to the pediatric population. There is a long-term graft function. You may have an inadequate transplanted nephron mass if you are getting smaller donor kidneys into larger recipients, especially if your neonatal kidneys are being transplanted. En bloc transplantation can be done. Again, on the other side, chronic ischemic injury, if you have large donors and you're putting them transplanted into small recipients. And this is a study by Gulani et al. Which showed that a low donor recipient body surface area less than 0.8 is a risk factor for loss of graft function at 1 year, 5 years post-transplant. Recurrent disease, again, we deal with kidney diseases which are unique, which have a higher risk of recurrence, like oxalosis, congenital nephrotic syndrome, Rasch syndrome, autosomal recessive polycystic kidney disease, and not to forget primary FSGS, mesangiocapillary glomerulonephritis, and atypical hemolytic uremic syndrome. So, you need to keep in mind, try to investigate what is the underlying disease before you aggressively jump onto a kidney transplant. Another unique complication which we saw, this is reversible posterior leukoencephalopathy, a 7-year-old child which we had transplanted secondary to FSGS. Third day, he had severe hypertension and seizures. In fact, a right-sided hemiparesis. The family was devastated. We put him on, controlled the blood pressures with nitroprusside, labetalol, amlodipine. MRI confirmed the diagnosis. We thought it was due to tacrolimus, switched him on to cyclosporin. But the results subsequently were dramatic. 3 months later, the MRI was normal. And from a child who had right-sided hemiparesis, this was a child who was back to his normal activity, cycling all the way. 5 years post-transplant, normal renal function. Again, avascular necrosis is something which is again perhaps maybe higher in children, because a lot of these children have chronic glomerulonephritis, history of steroid therapy in the past. This is a child who had, at 7 years post-transplant, came to us with pain and limp in the right leg. MRI showed avascular necrosis of the right hip, but fortunately it was in the early stage. We treated him aggressively with calcium, vitamin D, alendronate. He improved, continues to carry on, and now he's even done a 14-kilometer trek to Vaishno Devi Shrine, which is amazing for a child who had post-transplant avascular necrosis. Retransplant, second transplants again are a reality we have to live with. This is the same child I talked to you, and he was, back in Cambodia, ran out of immunosuppression, lost his graft, came to us back again in 2018. This time, second transplant was done, and now is, as you can see, this is the initial picture. He's happily, back to school, but something which requires, continuous growth is something which is unique. This is my experience, which was at Royal Children's Melbourne with Dr. Powell and Dr. Walker, and what we found was that the factors that influence growth are etiology, age at transplant, pre-transplant growth, renal function post-transplant, steroids, renal osteodystrophy, post-transplant sexual maturation. Growth hormone, unfortunately, in our country is very expensive, and we have used it only anecdotally, but this is a strategy which you have. This is the same child who underwent pre-transplant, and you can see he's outgrown me also, and he has been converted to alternate day prednisone, and he has had excellent growth in these patients thereafter. We also experimented with steroid-free protocol in children. The growth did improve, but as they ended up, this is the same child, ended up with a higher incidence of chronic antibody-mediated rejection. The outcomes, this is the initial experience of SUPGI. 1 year graft survival, 89%, 3 years, 70%, 5 years, 50%. And this was an era where, we had only innovative brand of cyclosporin, and there was also a fashion of, as I say, CNI withdrawal, and we quickly learned and retraced our steps. Subsequent experience from the initial 43 patients that I did at Delhi, 1 year survival of 99%, 5 years 85%, 10 years 80%. So as I said, much better survival than adults, mirroring the improved survival from SUPGI where I was earlier, 94.3% 1 year survival, 5 years 67% survival. This is outcomes from Fortis Healthcare. We looked at data across Fortis hospitals in the country. Rajiv was a part of it. 84 patients between 2007 to 2017, mean age 15 years, 27 girls, 57 boys, and 97% patient survival, 92% graft survival, 19% infection, and 12% rejection. So so these patients generally do well if they have on regular follow-up. So to conclude, non-immunologic risk factors are a major contributor to both early as well as late allograft loss, especially in children. Donor quality is an early determinant of long-term allograft survival. Surgical complications, especially vascular thrombosis, major cause of early graft loss in young children. Recurrent disease needs to be kept in mind. Opportunistic infections, PTLD, contribute either directly or indirectly to inferior graft outcomes. Adolescent and young adulthood is a high-risk age window assured with poor graft survival across demographic and immunological variables, largely due to non-compliance. And I would like to acknowledge Dr. Pulyanda, who's here. She was kind enough to share the preprint version of her papers and seminars on nephrology, which is a must-read, a very excellent publication for me. So I end on this note that a lot has been done, but a lot more needs to be done, and we have promises to keep and miles to go before we sleep. Thank you.
Thank you, Dr. Gulati, Professor Gulati, I think, for excellent deliberation on the pediatric transplants. In fact, when we got the training, there was hardly any pediatric nephrology in India. And then we trained in both pediatric and adult nephrology. So I have a few questions. One is, how frequently you use growth hormone? Because
so I can literally count an N of 1 out of all the patients. And the challenge is always the financials. So in the pre-transplant period, I tell the family, look, either we can use growth hormone, or if you have limited finances, you save the money for a kidney transplant. And my strategy is always beyond 1 year post-transplant to switch these patients, if they have had a reasonable run without any rejection, to switch them onto alternate day prednisone. And I have never attempted growth hormone in the post-transplant, because I know finances continue to be an issue in this. All the treatment here is out-of-pocket expenses, but I do have experience with growth hormone during my stint at Royal Children's Melbourne, as well as Hospital for Sick Kids Toronto. So our policy was that if at 1 year post-transplant, if they had a rejection-free period, and if their immunosuppression was minimized, all the metabolic complications were taken care of, parathyroid hormone was okay. This would be, if they fulfilled a set of criteria, then we used to use growth hormone. But I'm sure there are people here, Dr. Pulanda she's got much more experience here.
Yes.
Yeah, so we have used, like in India, we have used growth hormone, but we have used it after 1 year of kidney transplantation, because most of the time in India what happens is that by the time they are transplanting, the child is already beyond, say, 9-10 years. So most probably they need slight push. And in both cases, the outcome has been very good. Like there has been a distinct improvement in growth. Even they were on alternate day steroid, but still they had a distinct improvement in
I have
growth.
used several patients who are on nephrotic syndrome or CKD, not on dialysis. So I have used them, and there is substantial growth.
Yeah,
Several
normally
patients I
what
have.
our endocrinologist said that if they are on a high dose steroid, then growth hormone may not be working that well.
They
I
are
think
not
Steve
on
might
high
be
dose steroid.
having more in.
Yes.
Stephen Mars from London knows that we actually don't use much growth hormone, I have to say. We believe very much more in nutrition as well as other aspects. And in the transplant population, because we don't use steroids, we actually find out, and I'll be talking about growth later on, you find out that the kids do really well off steroids. Obviously, some of them need to go back on steroids if they have acute rejection. I was going to ask you what strategies you use for non-adherence. You kind of touched on it. But how do you improve the adherence in your population? And I note that your patient that you showed, who unfortunately died from COVID, he got retransplanted the same year that he lost his first graft due to non-adherence. And I wanted to know what program you have to try and improve the adherence with the second transplant.
Absolutely. I think this is one area, non-compliance is one area which we need to focus on because it really costs no money. And for countries like ours, it is a major cause of graft dysfunction. And I'm presenting a paper today. We have partnered with the industry, and it is called a patient support program using telemedicine. So counselors were hired, and the interest of the industry is that the patient continues to be on the medication. So it is called a Parichay Patient Support Program. And there are regular calls that go from these counselors to these patients who are enlisted. So we take the consent of the family. The patients are enlisted into this support program. What they get as a spin-off added benefit is that the tacrolimus levels are subsidized. By that way, we can track them. We can track the non-compliance also as well as the refills. So this has, we found this is a combined adult and kidney population across India. And with the use of this patient support program, we had a compliance rate of 93%. And I think that is one of the ways that we need to move forward. Over to you.
I think once the balatacept is freely available, that may be one area, because you can push the injection. You are sure that at least one medicine is getting.
But actually, when you ask the adolescents, many of them don't want to come for monthly infusions with the belatacept as well, so you have a problem that side too.
Yes.
Thank you.
Can I ask a quick question, Sanjeev?
Yeah.
You know how difficult it is often to get a donor even for the first kidney. So now many of the pediatric programs in the country are running into 20, 30 years, which is sort of the time when you might need a second graft. You showed a few patients who had second transplants, but Overall, how difficult is it? How many kids just drop out when their first graft fails?
So majority of them, you're right, do drop out. There's no doubt about it. And unfortunately, in our cadaveric transplant program, by and large, there are no special points that are given to children. And this is something I think, the organization needs to talk to NOTO and DGHS that children need to be prioritized. Obviously, there are economic advantages. As you can see, we can talk to them, give them rehabilitation data, how these children are becoming useful citizens of the country as compared to, elderly people who often get a second transplant more often. But second transplant is definitely a challenge, but things are changing. When I started 3 decades ago, even the concept of transplant was not there. And now when you broach this family about second transplant, and we have done quite a few, they are, open to it. That's why for the first transplant, now we always prioritize the grandparents, telling them that grandparents should be taken as
Is there an age limitation for the grandparents?
Well, there is no really age limitation. The oldest donor in the country, I think, is close to 80, 81 years. All you need to have is a good DTPF GFR. But always get the grandparents on board first and,
Thank you very much. I think we have to close the session. Thanks for a very interesting talk.